Good morning. This is Exercise Science 4700 Advanced Gross Motor Assessment, and today we are recording methods for the range of motion, neuro, and special test of the knee. We are liquored up, as you can see. We're in a different setting because they're replacing the roof where we were, and it's just too darn noisy. So, and another faculty member beat us to the other room by 4 seconds. So here we are, and this will work. Range of motion to begin with. We will do active range of motion and then passive range of motion. The knee is a modified hinge or ginglymus joint. It moves in the sagittal plane with a modified transverse plane. Medial lateral axis, it does flexion and extension in the sagittal plane. The last 10 degrees or 15 degrees of knee extension, the medial femoral condyle is longer, and the lateral femoral condyle has already covered its entire surface area. But the medial wants to cover all of its surface area. It's like up to a half an inch or an inch even longer. So the last 15 degrees, the tibia will rotate externally because of biceps femoris, or internally because of semitendinosus membranosus. This is called the lock home mechanism or screw home. We have that so that when we're standing, the knees can lock out and the quads can relax to a degree in order to recover, and the skeleton does the work of supporting the body against gravity. Also, the meniscus is very dynamic, and so it has to shape with that longer left femoral medial femoral condyle. Being a hinge joint, it does flexion and extension, like we said, and the last few degrees of extension. External rotation. It's called the extension lag if a person is not able to do the last few degrees of extension. And in fact, that's when the vastus medialis truly becomes engaged, generating tension, is that last little bit of extension. If they fall short, it might be because of edema, taking up the space so we can't lock it out, or pain or weakness of the extensors. And that's called an extension lag. If you would please, we are lacquered up. We already have a relationship. We don't need to do introductions. But may I have your permission to bilaterally test the range of motion, touch the soft tissues and bony tissues of your knee and related areas, and then do special tests to see if you have any pathologies?
Yes, you do.
If I do anything that makes you uncomfortable or hurt, communicate, please. All right? If you would, please step down. And you can cross your arms, or whatever makes you feel comfortable for balance. Please go down into a squat with me like this. This is our active range of motion. This guy's got some training because he went to a wide base of support and back up again. This is our active knee flexion, eccentric quads, and extension, concentric quads. As you know, the flexors are passive here relatively, other than eccentric in the glutes because of gravity doing the work. So also we have tibial, external, and internal. So without moving your thighs, kind of turn your toes out. You'll feel a little cringe in your knee, but try not to let the leg move out, but the lower foot. And that's all it is 10 degrees and 10 degrees. Very well. Now for passive range of motion, if you would please. Sit on the cot. And I am going to move your leg through the same motions, all right? Cupping behind the popliteal space, and at the ankle, I'm taking up through, I like to cup behind the ankle, better control, up through full extension and back down. And we can also do our external and internal rotation. The way you watch this, a real effective way, focus on the tibial tuberosity. You can put a black ink mark there and an ink mark here for better visual. I'm just going to put a finger. You can have them long sitting or short sitting. I do it short sitting because I'm going to do so many tests right there, and it's not so much back and forth and back and forth. So watching the tibial tubercle, you can see it is really relative to this dot, it is doing external rotation and internal rotation not so much. And we would test that bilaterally. This is our active and passive range of motion. For neuro, we have learned in the past that for sensation, you covered the hip, immediately proximal to the knee on an oblique angle, and down the medial knee, we have L3, dermatome. Lateral distal thigh across the knee and down the medial leg is L4, dermatome. Immediately below the knee and down the anterior shin is L5, and lateral leg is S1. For motor, manual muscle test, slide back into the table, please, right there. We're stabilizing the proximal segment. I'm also going to palpate the distal end of the proximal segment or the muscle groups, especially listening for this rectus, this vastus medialis to kick in the last 10 to 15 degrees. Would you please kick your foot up to here, and I'm listening with my hand, and relax. That is a 3 out of 5. Now I'm going to provide resistance at the end. I want you to kick all the way up and hold it at the top. Hold it. I'm going to try to push it down. You don't let me. And then we'll relax and go back down together. Let me know. I'm listening here, I'm listening here, and I'm listening here. Watching him. Resistance. Watch your biomechanics. Don't bend at the waist. Get down. We're in a different room, so I don't have my examining stool, so I'm just down where I'm working. Keep my center of gravity level pretty much with the area I'm working. Okay, I'm going to give you resistance and get more and more. You ready? And up, 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 up. Give me what you got. Hold, and relax, and down. Notice I return them down. We're doing this full range of motion. Yes, we are starting at 90 degrees of flexion rather than 130 degrees of flexion. Practice in the clinic is to do the hamstrings, the flexors, in this same position. Well, wait a minute. Please bring your leg up. Now relax. How's that going to check my motor? So we'll start with a 4 if we're in this position. Otherwise, I'll demonstrate in a moment, just for technique's sake, that client would be prone. So go ahead and take the leg up. Now pull your heel into my hand, and I'm going to feel down in here and pull, hold, and relax. And he just about strained and gave me a slap tap. So if you would please, a more effective, but I'll only go to it if I'm questioning the short sit. Slip on back on the table, please, on your belly. Of course, well, I'll come here so I'm not blocking the camera. We're going to stabilize the proximal segment, but it's hard. We're doing knee. It's hard to keep a 90-degree angle here. So we're going to cross our hands. Here is better because I am palpating. I'm here. Please bring your heel up to your bottom. Pull, hold, and relax. And again, look at my biomechanics. I'm not here working. I lowered my center of gravity, wide base of support, for the sake of the client and the longevity of your career. Knee extension is L4, knee flexion is L5. Turn around and sit up, edge of the table, please. That is, we've done dermatome, sensation, we've done manual muscle test, strength, L4, extension, L5, flexion. Now we have reflex. We do have a reflex. It's actually L2, 3, 4, but we're going to call it L4, simplifying predominantly the L4 nerve root. Sliding back so that we're stable here. The leg is completely relaxed. Good. And you're finding the base of the patella down to the apex. We're going to step just off onto the tendon and give it a quick wrap. Was that all natural? Okay. Don't usually get that much response. Let's see if it's symmetric. Quite close. Very well. So that is L4 for reflex. Now let's do special tests of the knee. Not a lot of supportive structures. Most of it is musculature. We have a medial collateral, a lateral collateral, those tests are going to be just like the collaterals of the elbow or a finger, any hinge joint, but these are larger and you might get a 150-pound leg of an offensive lineman. Tough to manage. So there's some mechanical advantage that's important with that. And then we have the cruciates. After that, we're looking at some swelling issues and some meniscus issues. A valgus test for the medial collateral ligament. You may lay back and get comfortable if you'd like. Now, I think a lot of books will say be here like this. I've had too many offensive linemen, I can't support the weight of their leg. I'm going to lock in to my waistline and turn slightly away. Heel of the hand is here on the lateral knee, and Hoppenfield speaks of, well, that's with cartilage, so no. Medial collateral, again, is just a thickening of the medial aspect of the capsule. Again, like the elbow, lock it out, and he's got some cubitus recurvatum you can see there. And let's see if that's normal with him. Yes, it is. So I'm not concerned about it. There, my eyes are always listening for something, and that didn't look right. So we check it. Any knee pain from any of that? Ever had problems with it? Relax your leg. Make sure you've got control of the leg. Lock it out. Bend it slightly, and I'm going to use my hip rather than push and pull with my arms. I'm going to rotate at the pelvis. Here, I've locked my elbow into my ribs, the proximal tibia into my thigh, and I'm not pushing or pulling, I'm just pivoting. And that will perform the test for me. I get a little laxity. I anticipate it'll be bilaterally symmetric. So we have some laxity, but a firm end feel. Again, I'm moving with my body because my arms are not strong enough to manage this big heavy leg. Bilaterally symmetric. Same thing with a lateral collateral. Let's do it from here. I'm going to turn you on an angle a little bit, if that's all right. Thank you. Dangle that leg. You all right there? Okay. Fine specimen of a iliotibial band there. Slight flexion. Heel of the hand and the pelvis. Push. Now the knee will want to go into a flexion. So make sure you are truly just doing that collateral. See that open up? Even get a dimple here. But it is a firm end feel. It's painless, and it's likely consistent with this leg. Thank you. Relax. Always make sure you've got control of the limb. And we have the same thing. You'll actually feel a clunk, and Hoppenfield speaks of that clunk. Watch his leg when I open it up, and that is more opening than most of the population, but it's normal for him. Open up. But when it goes back, the tibial plateau lateral to the lateral femoral condyle, clunk. Clunk, and the client can even feel that clunk. Clunk. Those are the collaterals. Meniscus is a cartilaginous disc that sits and mates with the tibial plateau. It's dynamic. The lateral meniscus has the popliteus muscle that ties onto it that helps shape it during knee action. So because it's more dynamic, the more rigid medial is the one most likely torn. We've talked about at the joint line, I'm on the lateral meniscus, I'm on the medial meniscus. The mechanism is a closed kinetic chain, and then pivot the femur on the tibia or the tibia on the femur. Tough for the tibia on the femur in closed kinetic chain. How many times do we do this? You're turning to go up another flight of stairs. You change direction in the hallway. You catch a ball, plant and cut. You cut to go across the court to get the pass. Hundreds of times a day. And those condyles seated in that meniscus will tear that. It's a compression and twist is the mechanism. So we're going to duplicate that. There, I charge you to Google McMurray test on YouTube. I checked it yesterday. There's a lot of them out there. They may differ a little bit, but you'll get the gist of it. And then do it as I've demonstrated or Hoppenfield describes. Difficult to manage a little bit. Need to have some access here at the end of the table. He's fine there. Let me have you come out this way a little bit more, please. Towards me. Yep, good. I need to be able to bend the knee and flex, and actually internally and externally rotate the hip. And the tibia. I want to duplicate torsion between the tibia and the femur. So, running down across the arch and cup the heel of the foot. Heel of the hand on the lateral knee, and my long finger is on the joint line. There's that crepitation again. But, and so I'm not just token cartilage. I felt something different there, so that's not right, and I'll look into it, and we did the other day. Now, I'm going to put a valgus on the knee at the same time as I extend the knee. I want the knee to go in and the toes to go out. External tibial torsion with a valgus on the knee. I'm listening here. I can feel a little click or pop, or the client can feel it. More often than not painful, but that is meniscus that's not right. A click or a pop as I valgus the knee and externally rotate the tibia and run the knee into full extension. Arm through the arch of the foot in order to have the mechanical advantage to externally rotate the tibia. Doing a torsion at the knee. Now I'm going to just reverse it. Arm across the length of the inside of the foot. It's difficult to do. Internally rotate the leg and varus the leg. So bow it laterally, feeling the joint line, extend the knee, and the tibia is rotated in. Notice it's not me bending at the waist and all kinds of things. It's my leg shifting that allow me to do it for my own mechanics. And you're testing to elicit pain, or that click or pop, or a lock. Now there's the reduction click test, which is the same as McMurray, but you tie them together, doing a figure 8, and you keep doing it until that heaped up piece of cartilage that's gotten in the way, that pebble in front of the skateboard wheel, and locked it up, becomes freed up. So I'm doing the varus and the valgus. Again, notice it's my legs that's really moving. He's getting a lot of grinding on his kneecap. Or you can change it so you valgus and then varus back up into hip flexion. Valgus, or change it so you varus. It doesn't matter. You're just going to keep doing the McMurray test and tying them together until you reduce or undo that blockage of the cartilage. That is McMurray and reduction click. We now have Apley's compression and distraction. If you would please, on your belly right here. Again, the mechanism is a weight loaded and a torsion, so I'm going to duplicate that. Stabilize the proximal segment. I'm going to push down on the tibia and push the meniscus down into the condyles, and then rotate that tibia. I'm grinding again. Apley's compression. If it elicits pain, it may be meniscus or ligament or capsule. So now I'm going to take the capsule out of the ligament, the meniscus out of the picture by distracting, taking the condyles out of the meniscus and rotate again. The ligaments are still engaged here, or the capsule, but the meniscus is no longer engaged. Here it's engaged, Apley's compression. Here it's not engaged, Apley's distraction. If it's still painful, it's other than meniscus. If it's not painful, where it was here, that is meniscus. McMurray, reduction click, and Apley's compression distraction for the cartilage. We've done the medial and the lateral collateral. Let's do the cruciates. On your back side, please. going to have you on a little bit of an angle, if you would. There you go. And we're going to have the knee bent so the foot's flat on the table. And I'm going to stabilize this leg right here. This is awkward because of the angle of the camera. The job of the anterior cruciate, if you cross your middle finger over the index finger, that is how they lay in your respective knees. Anterior cruciate prevents anterior displacement of the tibia off the femur. So we're going to duplicate that. See if I can't do this with this tibia. Around the heads of the gastrocs, fingers on the tibial plateau, and I'm going to pull straight forward. You can actually see this dimple open up here. He's got laxity once again. And when it goes back, it's clunk. Well, that's more than normal, but I'm limited on time, and I suspect it would be bilateral symmetric. I can't avoid it. I've got to test it, please. And relax. Same thing right there, as we suspected. Anterior cruciate. Now, when the anterior cruciate goes, the posterior capsule may also be involved. So I'm going to isolate. I'm going to turn the foot out. Now look at the line of the foot. The heel is going medial. So now I'm taxing the posterior medial capsule. It should be tightened when I externally rotate it. And the foot is pointing towards it. It should be tightened. So if that capsule is not involved, I'll be able to move less. And I am able to move less. So it's his cruciate that's sloppy, that capsule engaged. If I can move it as far, then you've taken out the cruciate and the posterior medial capsule. Just opposite, internally rotate, fix the foot, and I'm going to go here so that we can see the camera. Anterior drawer. The foot now is pointing toward the posterior lateral capsule. Anterior drawer, and again it is tight. So the capsule is very healthy on this fine specimen. His cruciates are lax, but it's normal. He's got some slop, but a firm end feel. To check the posterior cruciate is just the opposite. Heels of the hand, we're going to push on the flare of the tibia and the tibial tuberosity, pushing posterior. Anterior, posterior for the posterior drawer. That is for the cruciates. For the knee, we also have edema. If a person is not able to lock out their knee, it's because the architecture is too tight. There's not room for the edema. When you relax the knee, it makes more space. There's generalized and localized. Localized may be the prepatellar bursa, superficial infrapatellar bursa, deep infrapatellar bursa, or pes anserine. It can also be just around the kneecap. Here we can do localized effusion. Relaxing the leg, loosey-goosey. Good. You can tell you can't move the kneecap if the quads are tight at all. So this is normal, and this is actually the apprehension test. Patella can dislocate, and typically lateral. And it's a simple thing, but it's really ugly to see a kneecap over here. Not super disabling, it depends, but you can mobilize the kneecap if the quad's relaxed. Tighten up the quads, it's not going anywhere. Sucks it right down into the trochlear groove. Localized effusion, you can push edema back and forth under the distal end of the patella. This is just fat pad on him, relaxed. You can tell the difference, but it'll float back and forth. Another one is if there's generalized edema, there'll be so much that the patella will float a little bit. And you can push on it like the piano key of the AC joint. You can push on it and it'll drop down to the trochlear groove and then float back up again. This is called ballotable or ballotable test. Like a buoy in the ocean, you can push it down, lots of fluid under it, it'll push it back up for generalized edema or effusion. Patellar grinding test. I don't like this one. I think any knee, even healthy, hurts with this one. Try it on yourselves. I'm going to have you do it to yourself so you'll manage it, okay? What we do is relax the patella. We're seeing how healthy the articulation is between the posterior aspect of the patella and the trochlear groove, the articulating cartilage between the two. We can have tracking problems and it gets irritated. I won't have you do it until you do it to yourself. You're going to pin with the webbing of the thumb the base of the kneecap. Not 100%. Not 100%, but just resist it sliding under. Go ahead and contract your quads. There, you see how far. There's the apex. Now relax, and it slides clear down here. You're going to resist that a little. Not 100%, because it'll put a healthy knee through the roof if you don't let it move. Okay? I don't rely on it. I don't think it's a valid measure. A healthy knee hurts. So I'm going to have you put the webbing right here and resist it a little bit and tighten up your thigh. Yeah, you do that, but it's in Hoppenfield and it's commonly used. I don't think it's a valid test. I think a pathologic knee hurts, a healthy knee hurts. It's not a valid, it doesn't measure what it's supposed to. Those are the tests, the range of motion and the neuro of the knee. Thank you very much.